It's no surprise that squats are a common exercise, right? With the squat, there are many different variances of it, such as the strategy, coaching cues, and modifications. However, within all that variance, there's actually one constant within it. That one constant is the biggest squat mistake. To learn what that is, make sure you stick around to the end of the video where we address that and give you the solutions. However, we can't talk about that biggest squat mistake until we first understand why it actually became a problem in the first place. And in order to understand that better, we first need to start with squat biomechanics. So biomechanics are incredibly important because they help you understand normal so that you can better address abnormal. Some of us get hyper-focused on abnormal, but we don't have a good enough grasp on what that normal is to give that patient the true strategy for their abnormal pattern. So when it comes to the squat, the first thing we need to look at is the lower extremity arc of motion. This is the human body's alteration between external rotation and internal rotation. Now it does this to produce space and then produce power. Find space, produce power. And it continues to do this. Now, the human body does this everywhere. The shoulder, walking, breathing, we're always finding space, producing power. But as it relates to our squat, we can get very specific to see how certain phases are influenced by this. And once we understand the biomechanics, we then know, is that normal or is that abnormal? And if it's abnormal, we know what's normal, so then we can start to work on the normal aspects to get our patients moving better. So the very first thing we need to talk about is the lower extremity arc of motion. Now I have the pelvis model here to help better represent each of these phases. And what it comes down to is we have that alteration of ER, IR, ER like we talked about, but we can look at it as it relates to hip flexion. So 0 to about 60 degrees, we have an external rotation bias. 60 to 90 degrees, we have an internal rotation bias. And then 90 to 120, we go back and shift to our external rotation bias. Now, the squat is a very flexed or very flexion-based exercise, right? So you might be asking yourself, well, flexion is normally paired with external rotation. So why do we have this internal rotation moment at that mid portion of our squat? Well, what it comes down to is reorientation of muscles. The muscles actually orient different because of the positioning of the femur. Now let me explain. There's studies done that show that the glute max, certain portions of it, the anterior, the middle, or the posterior fibers, are either internally rotating or they are externally rotating less, which moves them towards more of internal rotation. The same thing can be said at the piriformis, right? Have you ever wondered why you do a piriformis stretch? And when you're in that stretch at 90 degrees, you actually put your leg in external rotation? Well, think about it. Your piriformis is an external rotator. So why would you put it in external rotation to stretch it? Shouldn't it be internal rotation? Well, as we see with our glute max, when you bring that piriformis up to that 90-degree mark, that is where it reorients. And let me show you on the pelvis to help better represent that. So if you think about where the glute max is, right, and the piriformis, we have a lot of insertion points coming around onto the femur, right? As the femur sits at its kind of neutral position, when these muscles contract, it externally rotates. As we move to that 60 to 90 mark, because the femur is more exposed, right? Look at this front side. It's more parallel, right? In line. So as the muscles come across, when they contract, it turns it this way. That motion is more internal rotation. And this is why we see that internal rotation. So the muscles, they don't really change, but that insertion point changes direction because of the position of the femur. right? So then we get our internal rotation. And then as the femur continues on, these muscles, because of how that femur is, it moves and shifts a little bit more back towards their external rotation pull. And it's really important to understand that. And I think a lot of us get it when it comes to the shoulder, right? A lot of us understand to get full shoulder flexion, you need to posteriorly tip the scapula. Well, in order to achieve hip flexion, you need to externally rotate and essentially posteriorly tip the pelvis or the innominate bones, right? So that's why we see that internal rotation shift as it relates to that 60 to 90 degree mark. And now what you can do is you can better understand why you might see certain things such as knee valgus around that 90. And you can start to understand, is that normal or abnormal? And if it's abnormal, we need to start to address it. The next important biomechanical aspect is the pelvis biomechanics. Now I know we just went over the pelvis as it relates to the lower extremity arc of motion, but we need to understand some of the basic motions here, and again, how they equate and actually why they are produced during each phase of our lower extremity arc of motion. So there are coupled motions that occur at the pelvis, and like we said, we can then line them up to our different phases of our squats, right? So external rotation, right, is always going to be coupled with counter nutation of the sacrum, flexion, and abduction. Okay, so let's bring that back. Counter nutation of the sacrum. This is our sacrum. Counter nutation is when it tips posteriorly. Okay, so think of more of a posterior pelvic tilt, or someone that kind of walks in almost like a sway back position where their glutes are tucked under them, right? This is more of that posterior pelvic tilt. Now, what happens? Well, that counter nutation or that posterior orientation actually starts to come from compression of muscles, right? So think about muscles being here. I know it's hard to envision sometimes because there aren't, but think of the muscles being here. As this compresses, it is going to push and open up the innominate bones. This is our external rotation moment. Now, conversely, internal rotation is when we see nutation of the sacrum. Nutation is when it goes forward, right? These are people that are more in our anterior pelvic tilt, kind of arched back with an increase in that normal lordotic curve that we have in our lumbar spine, right? So nutation is always going to be paired with internal rotation, adduction, and extension, okay? So what happens is the muscles back here are going to expand, right? To get this sacrum to move that way, like that, muscles need to have expansibility, okay? When that happens, we get a little bit more compression up front, and that's going to contract and move the innominates in more of this internal rotation, adduction. And because this is moving forward, relative to that, the innominate bones are moving in extension. So that's where you get those pieces. So that's the pelvic biomechanics. Now, as it relates to the lower extremity arc of motion, it's ER, IR, ER. Now, the motions are not necessarily this big. I'm moving it in this fashion for the demonstration purpose, but just know that we should have ER strategies from that 0 to 60, IR strategies from 60 to 90, and then ER strategies again from 90 to 120. So now you have a better understanding of the lower extremity arc of motion and the biomechanics of the pelvis. Now these are brief overviews, and if you're interested in learning more, I encourage you to check out our Performance Redefined course, where we go into much more detail as it relates to topics like this. However, with these two pieces, the lower extremity arc of motion and the pelvic biomechanics, we can now introduce our biggest squat compensation. Now, the biggest squat mistake, with the intention of a traditional squat, right? Because you can bias certain structures by angling things different, by moving different ways. But for this video purpose, we're thinking of a traditional vertical squat that you would see in a physical therapy clinic. Okay, so to me, the biggest squat mistake in that setting is the trajectory of the squat. What do I mean by that? The trajectory tends to be too horizontal when it should be more vertical. In other words, we coach our patients to move like an escalator when they should be moving like an elevator. This becomes a problem because it's really hard to obtain normal mechanics when you have a horizontal squat. And here's the thing, in the physical therapy world, people are coming to you because they have pain. That pain is a pattern. That pattern produces poor mechanics. So if we don't change their mechanics, we're just reinforcing their pain. So there are three big things that will come out of this. There's a long list, but these are three that I think are really important to understand. So the first thing that we see when it comes to a trajectory that's more horizontal is a limited squat, right? The range of motion will be limited to right around that 90-degree mark. Why 90 degrees? Well, go back to our lower extremity arc of motion. These individuals can't externally rotate from 90 to 120. Why? Because they're nutating and they are hinging, right? So instead of moving straight up and down as they go into their hip flexion, once they hit that 60 point, they continue to dump this way. So what does this create, right? Well, it creates the limited squat, but it also creates pain in the anterior hip, right? How many of you have dealt with anterior hip impingement? Have you ever wondered why? Well, if someone has a limited squat at 90 because they're here and they can't re-counter nutate, right? So they'll just keep hinging back. Remember we talked about what's happening here to allow for this nutation and this movement. Remember, you're creating space to move into. So there is expansion here. The tissues are allowing you to move there. Once these expand and open up, the front side is going to compress and tighten up. So the nutation at the 90-degree limited squat is usually met with anterior hip impingement because everything is compressed here and everything's expanded here. When in actuality, we need to compress to get the counter nutation. The counter nutation is like our shoulder blade tipping back, right? And that slight tipping will allow for normal mechanics. And the last thing that we see, so we talked about limited squat, we talked about anterior hip impingement, and the last thing we'll see is higher incidences of low back pain. This is more of extension-based motion when we see this nutation. That extension is going to continue up into that lumbar spine. So when you combine that with our difference of weight distribution as far as where the weight of the squat is, we see a lot higher of incidences as it relates to low back pain. So now we're aware of the biggest squat mistake. Now, what do we do to address the problem? Well, as we'll see with all problems, is it's usually multifactorial and there's many different areas that need to be addressed. However, I would like to provide you with 3 simple strategies that you can start to implement. Strategy number 1 is understanding that this is most likely a systematic, posturally driven pattern. That pattern is going to typically be one that is more in that anterior pelvic tilt. Now, go back to our mechanics and our lower extremity arc of motion, and you'll find that this anterior pelvic tilt posture is going to extend the system. And what this does is it creates an environment where these types of individuals are better at hinging and they're better at moving in that horizontal direction. So I like to say that these types of people are better at deadlifting compared to squatting. So they are predispositioned to move in that hinge or escalator type fashion. So what we need to do is address that root problem, right? So even if they have that limited squat, we're not getting stuck at the symptom of the hip. We're looking at the source of the pelvis. So what you can do is work in quadruped and breathing activities to start to get the rib cage back and to start to gain a little bit more of a counter-nutated or more of a posterior pelvic tilt. These types of exercises will go a long way to help them improve their verticality of their squat. Strategy number 2 is an anterior load. Now this is a modification, but it can be used beneficially as long as you're still addressing that main source of the posturally driven pattern. What the anterior load does, if you think of a goblet squat or a front barbell squat is it allows the rib cage to start to move back. And when the rib cage moves back, we move into that more of that posterior pelvic tuck or tilt to gain more of that verticality that we're looking for. So this is a great addition to your source-driven treatment to have and implement with people that are struggling with the vertical squat. Strategy number 3 is a slant board. The slant board can be beneficially used to help improve external rotation biases. What the slant board does is when you put your patient specifically in a heels elevated position, it is going to increase the amount of plantar flexion they have. Well, what happens is plantar flexion is part of that coupled motion of external rotation, flexion, and abduction. So what we're doing is we're giving more external rotation or plantar flexion, if you want to look at the ankle, through the slant board, which then is going to carry into tibial external rotation, femoral external rotation, and then innominate external rotation and counternutation of the sacrum. So this is why when someone has a very hingy, horizontal looking squat and you throw them up on a slant board, we like to say that it's increasing ankle range of motion. And yeah, it is. It's bringing them back, but it's doing just that. It's bringing them back, the whole system back, right? And we start an external rotation. So we are providing an external rotation modification, and in that type of case or scenario, you will then see an improvement in that verticality of the squat.